box where you can type questions either as they occur to you during the lecture or during the question and answer part of the webinar. You can also click the emoticons, the smiley face or confused face. I'm smiling right now, as you can see on the screen, to give us feedback during the lecture. Hector Rodriguez is Assistant Professor of Health Services and joined the UCLA School of Public Health in 2009. His research focuses on understanding the organizational influences on medical care quality and public health system effectiveness, performance measurement, and patients' experiences of ambulatory care. In today's lecture, Dr. Rodriguez will review important priorities for delivery systems research and describe the relationship between organizational design and organizational practices. Dr. Rodriguez.
Hi, Karin. Thanks for that great introduction, and thank you to those listening in for joining us this afternoon. You know, this is a really exciting time for healthcare delivery systems, and I'm happy to kind of talk about delivery systems research as it relates to the healthcare reform efforts going on. The focus of my talk today is on innovations and methodology considerations in delivery systems research. And so just as a little background as to my research interests and what brought me here to understanding organizational influences, before going back to my doctoral work, I was a consultant for the Permanente Medical Group for 6 years. And in that experience, I was able to observe and participate in some major organizational transformations, which really led me to question and there was so much variability in terms of success and failures of these large-scale change efforts that it really made me think about what factors at the team and at the practice level really influence the adoption of new and innovative practices. And so just to recap, my main research interests are really looking at the relationship between organizational structure and processes. So for example, do primary care teams structured in certain ways in terms of dedication to the team or working consistently with others in terms of the expertise available, does that affect the care team processes in terms of decision making and communication? I'm also interested in the extent to which these communication and teamwork processes affect the quality of ambulatory care. So both in terms of the clinical quality of care that patients receive in terms of diabetes care quality indicators and the general performance measures that most groups are subject to. In addition, with the renewed interest in patient-centeredness, I'm really interested in the extent to which the organization of care affects the patient experience. I'm also, as an extension of this interest, I'm also interested in understanding why certain racial and ethnic subgroups tend to have fairly large healthcare quality decrements in terms of processes of care as well as outcomes of care. And so today's goals really are threefold. One is to identify some important conceptual and methodology challenges in delivery systems research. Second is to describe ongoing research projects involving organizational analysis in delivery systems and how methodology challenges are actually handled in this work. And specifically, I'll speak to two main projects that I'm involved in. One is called ICARE, which is project that takes place in community clinics and health centers around California. And another project is working with the Center for the Study of Healthcare Provider Behavior on the VA's transition to the patient-centered medical home. And finally, I'd like to end off with a discussion of solutions to address some of these research challenges in terms of the methods and measurement issues. So just to get everybody on the same page in terms of what I mean when I talk about delivery systems research, earlier this year, because of the investments of AHRQ in healthcare reform and comparative effectiveness research, delivery system research has really, an expert panel or a group of investigators were convened in DC to identify priorities for the field. And in that meeting, the definition of delivery systems research was clarified, and Jeffrey Alexander, in a methods and metrics paper on delivery systems research, has spelled out that the goal of delivery systems research is to use research evidence to systematically identify which system processes, structures, or strategies are most effective for improving outcomes for patients, and to use such evidence as the basis for formulating policy to shift care to value-maximizing options across the healthcare system. So you see here important concepts of, a focus on system processes, structures, and strategies, and to assess their relative impact in terms of, from the patient's perspective or in terms of quality improvement. We need to choose and shift care to these arrangements that maximize value for the consumer. So a bit of the history of AHRQ and their investments in comparative effectiveness research. In 2008, the Congress doubled AHRQ's effective healthcare program budget to about $30 million. Following the next year in 2009 with the ARRA money, the American Recovery and Reinvestment Act of 2009, it actually provided additional funding in the amount of $300 million for comparative effectiveness research. Now granted, most of this allocation was for treatment comparative effectiveness, of looking at drug treatments versus surgical treatments and other things. However, in 2010, AHRQ really prioritized comparative effectiveness research on delivery systems. So this is really looking at the structures, processes, and strategies within the healthcare system, and identified two priorities for funding research in comparative effectiveness. One is related to system redesign or redesigning care delivery. So this is testing out team-based models and other sort of innovative models for improving quality of care and patient self-management. And then second is redesigning payment, either through bundled payments or through global payment arrangements or other types of incentives to produce quality in the direction that we all hope. So many of you may be asking, well, why is it so important to study the delivery system or the organization of care? And I think that we've made a lot of investments in medical treatments and randomized controlled studies of treatments. And we know that it takes about nearly 17 years to turn what is reported in the medical literature into the delivery system. So there's this huge lag in terms of innovation and uptake. And delivery system research really aims to assess how do we facilitate the integration of evidence-based structures and processes into the delivery system. For example, in the context of diabetes care, does a team-based approach that includes a multidisciplinary team with, a nutritionist, a health educator, a nurse case manager, do those yield better outcomes compared to an individual physician or approach or other configuration? Secondly, we know that when organizations undertake large-scale or change in their structures or processes, these efforts largely fail. It's estimated that about 80% of large-scale organizational change efforts do end up failing. And so comparative effectiveness research is really understanding the relative value of healthcare interventions, and delivery system research by extension is looking at comparing the effectiveness of various structures and processes in the delivery system. So today I'd like to focus using projects I'm currently engaged in as examples, but to really highlight 5 methodology issues in delivery systems research. The first issue is the issue of intervention fidelity versus organizational fit. And what I mean by this is when an evidence base is accumulated for a practice, whether it be drug treatment or a complex organizational intervention, the evidence base is built around generally a set of guidelines or procedures that are documented, and the evidence and the thought is among practitioners is that the evidence base is built around this whether it's a narrow population or whether it's a certain tools that are used, that evidence base needs to be mirrored and not really adapted for implementation. On the other hand, a lot of implementation scientists believe that organizational fit is really an important consideration. So we know that organizations aren't attempting change in a vacuum. So they've tried a lot of things in the past and have tested out and experimented with structures. And some of those structures may work very well for organizations. And so just because the evidence-based process is identified doesn't mean that the organization needs to adopt it in that very way. They may have other ways of integrating that practice that are more in line with the organization's resources or priorities. The second is a search for the unexposed. So when we think about introducing an organizational intervention into a clinic or a hospital, any medical care setting, we're really trying to implement change in organizations that have not been exposed to these types of interventions in the past, or haven't kind of adopted the intervention in such a way that it makes implementation unreasonable or a study sort of not enlightening. So the question here is really what level of exposure in terms of previous testing of practices means that the clinic is no longer eligible for inclusion in a study. The third issue really is around sample size and power. We know that a focus of delivery system research is understanding how do we implement evidence-based practice into routine clinical care. And so with that assumption, it really necessitates that we implement broadly. And so all eligible patients should be potentially exposed to that intervention, so the clinic level interventions. This is difficult because what it means is that you need a lot of organizations to compare if you're implementing at the organizational level or at the clinic level. So the standard randomized control trial will have patient randomization, which you can generate lots of numbers. And in implementation research or comparative effectiveness of delivery systems, really the level of intervention is at the clinic or organizational level. And so when you conduct quantitative analysis, you need to really have enough observations to make good comparisons. A fourth issue is measuring context. And there's a lot of debate as to, there's been a lot of testing of concepts of organizational factors. And then I would say that in my assessment that these are underdeveloped in the field of healthcare, and there needs to be more validation and testing of these measures. And then the final challenge is attributing performance and performance improvement. We know that the healthcare system has many layers in terms of, you just take physician practices for an example. There are medical groups, and there can be integrated or network medical groups, and under these groups are care sites, and physicians are embedded underneath the care site. And so at what level do you report and induce quality improvement? That's another very big tension in organizational and delivery systems research. So the current projects I'll be discussing today to highlight these research challenges, and I'd really appreciate any questions or comments or observations from your work in terms of what you're thinking about in terms of implementation research in your work or in your own projects. One is ICARE, which is Innovative Care Approaches to Research and Education for Diabetes, and that is this community clinic and health center project I mentioned. And then the second is the primary care team improvement work at the VA. And so this project ICARE Diabetes is really focused on implementing delivery system innovations in the safety net, in community clinics and health centers, federally qualified health centers and lookalikes. The project is funded by the Agency for Healthcare Research and Quality, and it's under the American Recovery and Reinvestment Act. So our team at UCLA was able to acquire one of these opportunities successfully. So just a bit about the structure of the research team. I'm the PI of the project. Alvin Kwong is the project manager. We have an executive team and 3 different subgroups or committees. One is the Interventions and QI Team Leads, which is led by the California Primary Care Association and Local Clinic Consortium. We have Tom Bodenheimer, an excellent trainer and primary care practitioner and leader in the field, really leading the quality improvement component. We have Dylan Roby here at UCLA leading the data infrastructure and quality team, and I'm leading the research team along with some great colleagues from RAND and UCLA. So why focus on diabetes care and the safety net? So for one, uncontrolled diabetes can really result in high-cost complications for the healthcare system. For example, lower extremity amputation or invasive procedures because of uncontrolled diabetes that have, these really challenging health effects and debilitating health effects. So they contribute really to the high healthcare expenditures in the United States. It's a very high prevalence condition. Second, research has really demonstrated that in general, that multidisciplinary primary care team approaches are critical and central to improving the quality of diabetes care and the quality of chronic illness care. The one limitation of previous research, though, is that it really tests out models that are not financially feasible for community clinics and health centers to take up. For example, there's been recent evidence around the benefits of hypertension management by pharmacists. There's been sort of nurse care manager or dietitian models of diabetes care management. But in the health centers we've talked to, these really aren't financially feasible given the patient volume at many of the sites and other issues related to financing. So the motivation for ICARE really is to explore lower cost interventions that community clinics and health centers are testing and compare their effectiveness. So the two interventions we're looking at are medical assistant panel management, so augmenting the role of medical assistants in primary care to do pre-visit coaching and checking for understanding, more integral in the visit, so expanding their role in that way, versus a community-based care management by community health workers. So we know that in the Latino community, for example, promotoras or navigators have been widely used for many years, and there's some evidence base around these workers for other conditions or issues like prenatal care. But the comparative effectiveness of these low-cost strategies for improving diabetes care quality really remains unclear. So we really don't know in the safety net what are the relative benefits of introducing one model versus another. So the aim of this project, ICARE, really is, aim one is to compare the effectiveness of the office-based medical assistant panel manager compared to the community-based health worker in improving diabetes care quality. So this would be the standard technical quality measures, HEDIS, for example, and patient self-management and their experiences of care. The second aim is really to compare the effectiveness of strategies in reducing racial and ethnic disparities in diabetes care quality, patient self-management, and patient experience. So we know that Latinos and African Americans tend to have, with exception of the VA system, which does a very good job in terms of disparities, in other settings, there tends to be large discrepancies between evidence-based treatment for diabetes care and patient self-management for patients with diabetes. And then finally, in the interest of clarifying this issue of why does it take so long, or why are some implementations successful and others are not so successful, the aim of the study is really to clarify the most important facilitators and barriers to the effective integration of these two strategies into routine care. So not only are we trying to understand whether these new models of care for health centers are actually effective in improving the care patients with diabetes receive, but we're also interested in understanding what factors at the organizational or team level actually facilitate or impede the integration of these new rules. So the conceptual model here, in terms of where do we see the panel manager, medical assistant panel manager versus the community health worker affecting the care of the patient with diabetes. Our hypothesis really is consistent with the structure process outcome model that's standard in quality of care assessment. which is, so the medical assistant, panel manager, and the community health worker are structures which affect the processes of care that patients with diabetes receive. So whether or not they received an HbA1c test, an LDL test, a screening for nephropathy. And this can affect the clinical encounter and patient self-management and ultimately the patient's control of their diabetes in terms of blood pressure, LDL, or HbA1c. The differences that we see in terms of going into this work, hypothesizing which one will be more effective, we think that they'll be effective but for different reasons. So we think that because the medical assistant panel manager will spend most of their time in the visit, in the office, working with patients pre-visit and post-visit, that they'll do a really good job of making sure that patients receive the appropriate treatments. So that's why you see this large, heavy line here from the medical assistant to the care processes bucket. Whereas, by contrast, you see the community health worker who's conducting interventions in community-based settings, either through leveraging community groups or doing group visits. And they would more directly improve patient self-management. So while they may not be connected very tightly with the delivery system, they will actually provide support to patients to improve their self-management. So in terms of the research challenge number one, in terms of fidelity versus fit in the context of this project, we're really, this slide that's not showing up actually was an assessment of the different roles that community health workers versus medical assistants take in care. And just to summarize, given that you can't see this slide, is that the medical assistant really focuses their work on the internal work processes within the clinic, ensuring that that diabetic patients receive recommended care, that they understand what the physician said after the visit, that they order routine preventive tests if they're due for the patient. By contrast, the community health worker is more involved, spending more of their time working with individual patients in community settings. So their efforts are really geared towards leveraging the community resources, whether it be churches or other existing community groups, or creating group visits in the interest of improving self-management. In terms of the timeline, as you know, the ARRA money comes with a lot of, it's fairly rigid in terms of timeline. So it's been a very interesting project in terms of engaging community health centers in their work. So the first year of the project really is developing the infrastructure to study diabetes care improvements across a diverse range of community health centers in different areas. And so the first year is really just to align all of the measures for these health centers for the diabetes care quality indicators. Then we'll field a survey, a clinician and staff survey, and based on the survey results, we'll actually select clinics from that and train them later this year, and the intervention actually starts at the end of this year. And at which point the intervention will last for a year with some supports for quality improvement that's led by the California Primary Care Association, followed by the evaluation period in year 3. I do see a hand here. I'm not sure if that went away. Anyway, moving on to, I do see a hand. I just am not clear. I'll move on. I'll try to figure out how to answer questions throughout here, but keep them coming if you do have questions. Second and third research challenges here are really about sample size requirements for organizational research. So we know that randomized clinical trials of patient-level interventions, they really don't have to think about this clustering issue unless the design is a clustered randomized trial. So in terms of organizational research, one of the challenges, like having enough clinics to do a statistical comparison of intervention effects, given that the intervention is done at the clinic level. The second issue is a search for the unexposed, this idea that we have to really understand the history of the clinic and what they've embarked on to truly characterize that clinic as not being exposed to the intervention you're trying to implement. And so again, just to underscore that this project, really a basis for sampling, is conducting these assessments of organizations, so clinic assessments, and to use these assessments to actually sample clinics for the intervention. So to the conceptual model, we feel that implementation of these new staff roles will be impeded or facilitated by three main factors. So organizational readiness for change is one factor in the previous literature that has been, pretty central to the uptake of evidence-based practices. And organizational readiness to change is not just this affective, attitude regarding change. It's really specific to the intervention that you're trying to implement. So what is the readiness to change construct really has the extent to which there's evidence base for the quality improvement intervention, and how do people perceive that evidence base. The other domain of readiness for change is the quality of the organizational context. And then finally, it's the capacity of internal facilitation. So what do leaders do concretely to influence implementation? The second factor is the baseline care team functioning. So we know that primary care, there's been a lot of research that highlights that care is often siloed, and interdisciplinary care is easier said than done. We know that patients prefer continuity of care, and that in order to make care experiences real for patients, the team needs to have effective communication, clarity of roles, have good coordination of their care processes, and psychological safety, which is people have to feel safe raising issue with work at hand. And then finally, the final contingency of implementation really is looking at the structural capabilities of practices. So how sophisticated are the clinics in terms of data capture, or using patient reminders, or to what extent have they implemented features of their electronic record. So we feel that these three factors, we're really examining which one is really most salient in influencing implementation, or is there a kind of interaction among these factors that will predict improvements in diabetes care quality. So in terms of sampling, this idea of searching for the unexposed, as a way of addressing the sampling issues, we wanted to make sure that the clinics could actually engage with us, that they had data quality that was sufficient for enrollment. To do, the pre-intervention period is happening now, and it's really important that we have electronic measures that can actually assess intervention effects with. And so we really required that they have a diabetes registry that's operational since the beginning of last year, or that they've implemented an electronic health record. And we identified 18 sites for inclusion in either the control or intervention arm of the study, with these clinician and staff surveys that assess team communication and organizational readiness for change. We're going to develop a readiness score based on the various factors, and classify clinics as being high, very ready, moderately ready, or low readiness. And from each of these buckets, we're going to choose one clinic from the intervention, each intervention, and we're going to choose 4 from each bucket as a control clinic. And so you may be asking yourself, why so many controls, and why don't you invest more in the actual intervention? And the rationale behind this is intervening is pretty expensive. We're supporting the intervention and quality improvement support, as well as providing data submission stipends. The reality of working in community clinics and health centers is that you really do have to work collaboratively and provide some incentive for them to engage. And the rationale is that they're being asked for so many different forms of engagement in terms of improving electronic use, electronic measures, in terms of implementing components of the patient-centered medical home, etc. On to the next research challenge, which is this idea of if we're interested in understanding what baseline factors or what clinical or organizational factors affect implementation, we want to have really good measures of these organizational factors, so the team functioning, readiness to change, and structural capabilities. I've narrowed in on these promising measures, the 3 that I've identified, because of previous research has really underscored their importance in implementation. Nevertheless, there's been a really scarce study of linking these measures to quality improvements in technical quality or in patient experience. So we know that implementation readiness really affects implementation processes, and we're trying to link these really with the changes in the patient experience, quality of care, and the self-management of patients. So I've reviewed these domains already, so I'll click right through them. Underscoring psychological safety as one of my favorites in terms of healthcare settings. So just to reiterate, this idea of psychological safety is really that, given that we have so many hierarchies or status differences in healthcare, it's really important that we ensure that lower status members have the ability to raise issue with the work at hand, to take issue with outdated routines. In the transformation of practices to patient-centered medical homes or more patient-centered practices, there's a lot of processes that will become outdated in the clinics, in terms of the way that teams interface, in the ways that patients flow through the system. As a result, there's going to be many processes that are outdated, and staff need to be able to take issue with that in order to make this transformation happen. So we're really interested in quantitatively assessing through these surveys whether that is true. So you may be asking yourself, what is a team in healthcare? How do we even define it? And the jury is still out on the definition of the team. So another major issue related to delivery systems research, specifically team effectiveness, is the boundaries of a team and who ends up defining these. So in the literature, there's been 4 major ways that teams have been defined. So in studies of teamwork or team effectiveness or team influences, one way is defining the team through using an organizational informant. So the practice manager or the physician lead takes a list of the clinicians involved in the team and indicates which team members are associated with which team. So this definition clearly is based on one informant's opinion or ideas of the configuration of teams. There's little opportunity for having overlap in membership. So if a nurse practitioner, for example, supports more than one teamlet or small team, how do you sort of define that using this method? Second issue or way of measuring teams has been through administrative data. So administrative data would be that we look back at the visit patterns of clinicians that work in a practice together and define the boundaries of the teams based on where we see the visit activity unfold. So if we see that Dr. A and nurse practitioner B tend to have overlap in their patients, then you could draw the boundary in that way. The third way that teams have been defined, care teams have been defined in previous work, have been through provider surveys. So an example of this would be surveys that ask clinicians, which of the following team members do you consider part of your teamlet or team? And they would mark off the teamlet member names or roles. And those characterizations of the team will be used to study the team and the boundaries of the team. And then finally, increasingly popular method of defining teams is asking patients. So you can imagine, given that care invokes, one person's care, a complex patient may invoke a bunch of different clinicians in their care, and the patient may view the constellation of these providers as a team. But the system may not define these members as necessarily a bounded team. So many in the field believe that maybe we need to transition to patient-centered definitions of teams. But then that patient-centered definitions definitely come with their complexity as well. So how do you actually, when the patient has a different view from an organizational definition or administrative data, how do you reconcile those differences? In addition, it's unclear whether any of these 4 methods actually is better than one another. So we don't know whether using a definition defined by the organization versus the patient actually it has a different relationship with patients' experiences or the quality of care that patients receive. So as you can see, there's lots of opportunities for young and eager researchers to kind of get clarity on what do we mean by teams and is it consequential to quality assessment. In terms of structural capabilities, just to get concrete about this dimension of measuring organizational context, really what we're focusing on in this study is systems and resources for assisting patients with self-management, tools for population management like registries and the functionalities of the registries, electronic health records, how they are used and what their capabilities are, the extent to which performance feedback and measurement is conducted at the physician level or at the site level, and whether that information gets fed back to clinicians to make changes in care. And also advanced access to care in terms of being able to see your PCP and also quick access to care. The final research challenge that I'd like to discuss, and then I'll end kind of the presentation of these research challenges, is really the attribution of performance and performance improvement. So at what level of the organization do we try to intervene? Is it in primary care? For example, in this diabetes care project, when we receive quality information, should we feed back to individual doctors through report cards? Should it be done at the team level? Or should it be done at the clinic level or in an aggregate organizational level? And the extent to which you choose one level versus another, really, there's face validity issues, does this make sense? And there's second, statistical issues, which are to what extent does performance on this performance indicator, let's say diabetes, let's say sugar control, HbA1c control for diabetics, is that the accountability lie within the care team or within the individual clinician or the care site? And you can actually use statistical methods to tease out which level is contributing more than the other. But in the area of performance measurement, there's many, in comparing organizational performance in delivery systems research, there's really a handful of concerns. One is, what level of reliability do we need to compare organizations for various metrics? So comparing organizations or physicians on a patient experience measure might be appropriate because physicians have a lot to do with the clinical interaction and communication. Whereas if you grade or compare physicians or organizations based on a factor that they have less control over, let's say the extent to which patients have control over their LDL. There's diet and exercise, all these other things that clinics can influence, but ultimately have some limitations in their control to influence. So sample size requirements becomes a real important challenge in the context of making comparisons. Second is risk of misclassification. So what this means is that when you develop a cut point, so if you're not if you're determining high versus low performance, what is the risk of misclassifying organizations or physicians when you do those sorts of things? Finally, who does this patient belong to? In community clinics and health centers, this is a huge issue, that patients use multiple sites or organizations for their care. And I think there's a lot of initiatives, really pushing towards panels and panel management, but the reality is still that there are attribution issues, that patients may have activity across a wide range of organizations. And so who do you attribute that patient to? And then finally, absolute versus relative performance comparisons. To make quality improvement or performance improvement more powerful, is it better to use a threshold or a standard of excellence, or do we use rankings? So compare percentiles or quartile ranks. So just an issue about absolute versus relative performance comparisons. This is really contentious because relative performance comparisons means that there will always be a set of losers. So there will always be a bottom quartile or a bottom tertile. Whereas an absolute performance scoring system would mean that anybody can achieve that level of performance if they meet that standard. So there's not a forced set of winners and losers under that circumstance, which really can have differences in terms of inducing improvement. So just a quick, I'm going to fly through these, but reliability of a measure really is a function of how consistent the results are within the unit that you're trying to compare. So do patients within the same practice tend to have the same patterns of care or outcomes of care? And to what extent can you tell physician groups or physicians apart from one another in a performance framework? That's really reliability. And so if patients don't agree in terms of a patient-reported measure about the care that they're receiving, or that there's really inconsistent levels of care for the same condition within a group or a physician, then you'll have really low reliability, and this would be a poor measure to use for comparing organizations. Whereas if patients tend to agree or have similar experiences or levels of care, then this is a fairly good measure to use if there's still variability across the physicians on that performance measure. So risk of misclassifying is this idea where, in this example here, you could see that at the 50th percentile, we created a cut point. This is a measure that tends to have better performance, and the 50th percentile is associated with a score of 65. And as you can see here, as the measure becomes less reliable in terms of it being a factor that the physician can influence, you could see here that it is at 0.7 reliability, which is the worst. There's a substantially larger risk of misclassification. So this gray area is where you would call a high-performing physician, a moderate-performing physician high, and a top-performing physician you might categorize as low or moderate. And so, risk of misclassification is a real issue. And as you introduce more cut points in the reporting framework, say that you want 3 categories now, that you run a even higher risk in this middle tier of misclassifying organizational units or physicians. So the issue of reliability of performance measures and the extent to which you can attribute performance to individual physicians or groups really depends on the reliability of the measure and the sample size that you have. And I think this has been a really contentious point for quality improvement. In an example here, my work at the University of Washington with Doug Conrad in a statewide pay-for-performance initiative that one insurer embarked on, we really found that the medical groups really didn't have enough sample to achieve reliable comparisons of these groups. So there are substantial financial incentives involved in this program, and yet we could only characterize with 0.7 level, the minimum standard of reliability, at best 55% of the observations, which was diabetes care. But for other measures like asthma treatment and well-child exam, there really wasn't sufficient sample in each medical group's information to actually do reliable comparisons. So in the context of defining losers or winners for this initiative, there was a high risk of misclassifying performance. And I think I'll stop with that and take any questions. I'm going to, we probably have like 10 minutes left or so. So I'll entertain questions.
Thank you, Dr. Rodriguez. We have one question already from Christina on the screen. Is there an arm where both interventions are given? It seems that the interventions may be synergistic.
Hi, Christina. I'm very familiar with Christina. And Definitely. Actually, the previous research has looked at the synergies at the patient level. Unfortunately, the study really is empowered to have or resource to have an additional arm. The research at the patient level, however, has demonstrated that there are synergies here, that at the patient, when you randomize patients to either receive a health worker or a medical assistant, panel manager, or sort of both interventions, that the arm with both tended to have larger effect sizes in terms of quality improvement. I think in this study, patient self-management reports. However, they weren't dramatically different from either of the other arms. Although it was different, it wasn't statistically significant. The difference here in this study, however, is that it's an implementation study, which means that patients aren't randomized, which would mean that in order to test the combined effects, we did have to have a whole other set of clinics that were randomized to that arm. But good point. There are definitely efforts, and in fact, in our work of trying to see whether clinics were exposed to these interventions in the past, many had embarked on navigators or health educator models in the past, but just very different, organized very differently in terms of, like a centralized navigator service that serve the needs of multiple clinics, for example, or crossed disease categories and worked on various clinical issues. So we're implementing a specific form of navigation and outreach, which is specific to diabetes care and has some linkage with the healthcare team.
Thank you. Also, in your presentation, you emphasize the importance of teamwork. Are there evidence-based team communication strategies that delivery system leaders might consider adopting?
Sure. That's a great question. Thank you for that. Just to underscore this idea, it's really been challenging. I get asked a lot about, are there interventions, simple, discrete interventions we can implement to improve teamwork and team communication? And there are some evidence-based out there. There was a recent review in the Journal of Health Policy that really highlighted the potential for communication interventions to improve teamwork. And I think that teamwork in the context of ambulatory care or primary care is really different, and that's for many reasons. One major reason is that most of the research in healthcare for communication is focused on surgical teams or inpatient teams where the handoffs are very apparent, that if a patient goes downhill, that team members tend to be able to observe that, or communication, in-person communication is more feasible. Whereas in ambulatory care, the interdependencies among the team members are really looser, and so a physician may have responsibility for a diabetic patient shared with a nurse care manager, but see those different clinicians on different days. The information between those two encounters may not flow nicely. And so one of the main ripe areas for testing in ambulatory care, in my view, is structured communication, which means other words for this are huddling before shifts, to clarify roles, to clarify the work at hand for the day, and sometimes to check in terms of things that didn't go so well the day before. This type of reflection, in my experience, is very rare. Primary care clinicians are very stressed in terms of, and most face productivity incentives primarily, and so this sort of taking time away from patient care to clarify your team roles is often seen as not really valuable. But through the patient-centered medical home demonstrations and other communication improvement efforts, we've really seen some in the literature anecdotes of teams really transforming through more effective communication and coordination. So I would say that the biggest priority is just creating structured opportunities for primary care teams to meet. And when I say teams, I don't mean the whole department gathers around and discusses which doctors are here and which doctors are not. You'll see some teamlet huddle examples in YouTube and other things that do have that model. But what we really think would be a priority would be smaller teamlet, sort of with the micro team of the primary care physician, the medical assistant, and the nursing professional, possibly a rotating department manager be involved in these smaller teams where you're really creating a feel of organized care for the patients who belong to that PCP's practice.
Victor, we have 2 more questions on the screen.
Great. So one of the questions is, what types of things should providers or provider organizations be doing in their EHR implementations to help QI processes and research regarding provider and provider organization performance? This is a great question, and a lot of these electronic health record systems, I think the priority really is to have good interface with practice management systems specifically. and the rationale is that practice management systems are largely the area where I've seen teamlet or team member mappings occur. So when providers are kind of defined in the delivery systems, information systems, the practice management system is largely the place where those team definitions occur. And so the interface between practice management systems and electronic health records or registries are probably really important for vendors to collectively start working out challenges in integrating these disparate systems. In fact, in our work here on the team with ICARE, we found that clinics are having the same interface problems with the exact same vendors. And so we're trying to facilitate vendor dialogue, but this is just a real challenge that leaders really need to be attentive to when adopting systems. So if you're going to measure teamwork and prioritize teamwork, you have to ensure that your practice mappings and the data for teams sync nicely and easily with clinical quality data. And another question really asked, in your background review of systems, what organizations or best practices have you noted are managing chronic condition patient populations like diabetes well? So I think that the challenge here is that in any kind of research on systems is that the interventions sometimes are implemented differently. The most consensus I see in multidisciplinary teamwork come from the chronic care model evaluations, where always in these evaluations, teamwork and interdisciplinary care are always highlighted as the path to achieving better quality of care for patients with chronic conditions. Dr. Wagner at Group Health and Bodenheimer and others really have highlighted the importance of teams and their effect in managing chronic care. Physicians need to think about organizing care beyond the visit model to use these other clinicians to provide self-management and other support. So I do think the team-based approach is the way to go. I think the questions now that we're struggling with are how to. How do we make these teams real for patients? How do we make the teams an added value to patient care and their experience versus a distraction to developing a relationship with the primary care doctor? And so I think more of the effort is not about what structures do we put in place. It's more how do we make these structures work in a way that's centered around patients' experiences, their self-management, and their efficacy around managing their health.
Also, when you were talking about fidelity versus fit, you made it clear that intervention has to be, somewhat standardized for the results to be measurable and comparable. So what are some areas where flexibility can be given, and what are some areas where it cannot be given?
That's a great, you're asking me the controversial question, and I think the jury's out here. I think, interestingly, an article just came out that was related to hand hygiene and the implementation of evidence-based hand hygiene practices. And that study, that's a fairly discrete intervention. You know, it's not super complex. And so Fidelity really was influential in the improvements in infection rates. So the more that the implementers adhered to the intervention of hand hygiene that was evidence-based, the better the outcomes or improvements that were observed. However, in my view, when you're dealing with complex interventions that have so many different interfaces within the clinical context, that it's not as simple as implementing, you know, a hand hygiene protocol, that there may be existing resources or infrastructures or you know, technologies that necessitate an adaptation to the care, the evidence-based care process. So in my view, I tend to be on the side of the fence where some adaptation is important to fit the organization, and I actually think it's a precondition for successful implementation of complex interventions. The jury's out, though. I think in terms of delivery systems research, where we need to go is really assess this issue empirically. Does Fidelity for complex interventions actually yield better outcomes than approaches that are adapted? I think this is something that we definitely need to study and empirically assess.
Well, it looks as if there are no more questions from our participants. Dr. Rodriguez, would you like to add anything or ask a question to our audience that maybe they can answer by smiley or confused face? Some question that you'd like to put out there?
Sure. You know, I see the names here, and I know many of you are all fellow researchers. I was wondering the extent to which you know, this fidelity versus fit is a very controversial issue. I would like you to give me a smiley face if you are on the fidelity. Fidelity would mean you adhere to the evidence-based spectrum in general. I know this is a loaded question, but if you can mark a smiley face, that would be great if you favor fidelity over fit. And I would like to hear if there's a way of participating, that would be. I see a negative face and a smiley face. So that's great. And how about now let's talk about organizational fit. Which of you feel that fit is more important than fidelity in implementation research? Oh, here we go. We have a bunch of implementation researchers here. And the rest of you, I imagine, are asleep or on the fence. Great. Well, thank you for that interaction. I'm glad I'm not the only one on this you know, organizational fit area. I do think it's an important tension. And you know, the approach that I'm taking in this study is really measuring fidelity, so that at the end of the day we can say, you know, what is the divergence between the way that the intervention was intended to be implemented versus the way that it actually played out, and did this relate to improvement at all?
Well, thank you so much. We are out of time. I think we can all join Ellen and Darren as we are clapping for a great presentation. We will continue the conversation in May with Dr. Michael Prelip. The title of the presentation will be Farmers Markets, Corner Store Conversions, Are They Enough to Change Community Health? So please mark May 18th in your calendars and join us at noon, since this promises to be another hot topic. Thank you all for participating, and have a wonderful rest of the day.